Good morning, everyone. For the clinical meeting today, I am presenting a spotter actually on the topic silent storm. So, short history: Mrs. L, a 59-year-old postmenopausal female with no known prior comorbidities, presented with complaints of right lower limb swelling associated with pain for 20 days. And to the OPD, when she presented with sudden onset of breathlessness since 5 a.m. with MMRC grade of 3 and past history of COVID-19 in September 2022 requiring ICU admission and NIV for around 6 days, and family history was not significant for malignancies. And examination wise, she was conscious oriented but tachypneic with a respiratory rate of 36, heart rate of 112, and saturation was 93% in room air. She had no general examination findings. And local examination wise, she had a right lower limb pitting type of period edema, which was not warm, and there was calf tenderness. Auscultation wise, chest was clear, normal S1 and S2, and other systemic examination was normal. So clinically, it looks she presented with a right lower limb swelling and a sudden onset breathlessness with no previous comorbidities, and vitally she had tachypnea, tachycardia, and the chest was clear. So her chest X-ray showed a picture like this. So clinically, she presented with an acute pulmonary embolism secondary to a right lower limb DVT, but her chest X-ray was showing a appearance like this. So my question today is, what are the probable differential for this chest X-ray appearance? Would anyone like to chime in for the differentials? This is the chest X-ray. Heart failure. Anybody else? Another clue is that this the chest X-ray has nothing to do with the clinical presentation here. It's an incidental finding. The patient came with other complaints, but then it was an incidental finding. Yes, it can be tuberculosis, miliary type. Pulmonary infarction, we can't confirm with this chest X-ray. It is not a focal patch. So probable differentials for these miliary opacities, we can consider tuberculosis, then disseminated, sarcoidosis, amyloidosis, mycosis. It can be pneumoconiosis, silicosis, talcosis, or a metastasis, or a pulmonary hemosiderosis too. But what did her chest CT showed? This was the HRCT picture. HRCT cuts. So this is called as the sandstorm lung. And the diagnosis of pulmonary alveolar microlithiasis. This is a telltale sign of pulmonary alveolar microlithiasis, where we can see the sandstorm, that is the microliths, calcium deposition along the alveolar walls. And there is a particular sign called black pleural sign seen in the CT, where you can see there is a whiteout lung, and between the rib cage and the lung, we can see a black, the lucency of the pleura will be seen. Actually, the pathognomic sign here is because of the subpleural cysts, which is showing as a lucency here. That is called as the black pleural sign. And it is also a pathognomic sign of pulmonary alveolar microlithiasis. So that, as I said, according to the patient's history, she had a COVID in September 2022. So we had a doubt whether she had this microlithiasis prior to the COVID, or did she develop after the COVID. So her old radiographic films during the admission for COVID-19 showed a similar picture. And the CT did not comment about the pulmonary microlithiasis. They had treated like a severe COVID. Post that, there was no normal X-ray. All the subsequent X-rays were the similar findings only. So a short note about what is pulmonary alveolar microlithiasis. It's an autosomal recessive rare genetic disease with high penetrance and most often associated with consanguineous marriages. And it was first described by scientist Malpighi, who said it's Invasculus pulmonum innumeri lapillicans, and it is because of the mutations encoding sodium phosphate transporter. And it has been very less reported cases numbers only 1100 only has been reported so far, and most of them are diagnosed during the third to fifth decades. And in the familial cases, female predominance is more. So pathophysiologically, actually in type 2 pneumocytes, we have a predominant transporter called as the sodium phosphate co-transporter. When the surfactants get metabolized, the phosphates are pumped back into the blood by this sodium phosphate transporter. When this is affected, the phosphates are not cleared from the alveoli, which leads to a microlith formation. And we can see rounded microliths in the alveolar spaces in this picture. So natural history wise, the patient will have predominant symptoms of dyspnea and cough, and this type of disease is seen highest prevalence is in Asia only. And with time, these alveolar walls will become fibrotic and they develop a respiratory restrictive type of ventilator defect and reduced DLCO, and they can progress to a respiratory failure and a cor pulmonale. Diagnosis typically made from a HRCT along with a BAL. So radiologically, they can progress like it has 4 stages. It's a pre-calcific phase. Then they develop a sandstorm lung. Then with obscuration of the left heart and the heart and the lung margins, and at last they develop the whiteout lungs. So this is what these are the HRCT findings which I was telling about: sandstorm lung and the black fluorescine. So management wise, it's an orphan disease. We have to offer genetic counseling and vaccination just as we treat any chronic lung conditions. And the only effective therapy that has been shown benefit is lung transplantation. Post lung transplantation, there has been no evidence of recurrence of the disease, which says that it's a localized lung transporter pathology. And bisphosphonates and systemic steroids have been tried, but they did not show any therapeutic benefit. So take home points, this case is a classic presentation of pulmonary alveolar microlithiasis. Most of them do not present with clinical signs. It's a incidental finding, and it is diagnosed by the sandstorm appearance, and lung transplant is the only curative option. Thank you.
Any questions?